Thank you for joining our Debbie's Dream Foundation Curing Stomach Cancer webinar series. Today's webinar is titled Unraveling Ascites and Peritoneal Disease and Gastric Cancer, a Fluid Problem, and it is the sixth in a series of 12 monthly webinars. I am Mary Margaret Kilmeyer, and I will be moderating today's webinar. I'm the Programs Director for Debbie's Dream Foundation Curing Stomach Cancer and a licensed marriage and family therapist. My clinical and research background is focused on working collaboratively with doctors, patients, their families, and members of a healthcare team. We would like to thank our title sponsor, Boston Biomedical, and our platinum sponsor, Lilly Oncology, for providing the funding to make this webinar possible. You will be able to ask questions during this presentation. You can type your question into the white text box that appears on your screen, and we will address questions at the conclusion of the presentation. In addition, the recording of this webinar will be accessible in our website in the lecture library. First, I will share information about our president and founder, Debbie Zellman, and Debbie's Dream Foundation Curing Stomach Cancer. Then we will hear a presentation on ascites and peritoneal disease and gastric cancer from Dr. Samuel Klempner of the Angeles Clinic and Research Institute, and conclude with our Q&A session. Pictured here is the president and founder of Debbie's Dream Foundation Curing Stomach Cancer. Debbie was diagnosed with stage 4 stomach cancer in April of 2008. A practicing attorney and mother of 3, she had no risk factors for stomach cancer, and her symptoms were very vague. At the time she was diagnosed, she was told that her chances of being alive in 5 years was only 4%. She's endured harsh chemo regimens and targeted treatments and has experienced many recurrences over the 9 years since she has been diagnosed, and she is still a patient to this day. Debbie founded DDF in April of 2009. As an organization, we're a member of several advocacy coalitions, including the Deadliest Cancers Coalition, the Patient Equal Access Coalition, the State Patient Equal Access Coalition, and One Voice Against Cancer. Debbie serves as a patient advocate on numerous committees and task forces. Some of you may be familiar with the facts and statistics about stomach cancer, and they're continually being updated. In 2017, it's estimated that more than 28,000 Americans will be diagnosed with stomach cancer, and more than 11,000 will die. 80% of all patients in the United States are diagnosed at stage 4, when the 5-year survival rate is only 5%. And the incidence rates in younger populations has increased, while the expected frequency has been on the decline. Yet very few people know much about this deadly disease. Debbie's Dream Foundation is dedicated to raising awareness about stomach cancer, advocating for advancing funding for research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiesdream.org. In the few short years that DDF has been in existence, we have achieved many great milestones. We have 27 chapters across the U.S., as well as chapters in Canada and in Germany. And there are events going on around the country all year. Our patient resource education program helps patients, their families, and caregivers around the world by matching them with survivors and caregivers using disease-specific criteria, including stage, biomarker, and location, and more. We host educational webinars, such as the one you're listening to today, and symposia year-round. And our website contains in-depth information about stomach cancer that's translatable into more than 60 languages. We have also provided $650,000 in research grants and advocated on Capitol Hill for our annual Stomach Cancer Advocacy Day to add stomach cancer to the Department of Defense's peer-reviewed cancer research program, resulting in nearly $12 million being awarded to stomach cancer researchers. Here you will see a snapshot of our website's homepage with links to numerous resources, including our online stomach cancer support community. And here, as you can see, there are many events that are going on around the country and things coming up on the horizon, including our teams participating in races and runs, such as the Chicago Half Marathon and 5K. The annual Dream Big Luncheon, celebrating Debbie's 50th birthday, will be on September 25th, 2017 in Weston, Florida. There are also golf tournaments in November in North Carolina and Florida. In addition, the month of November is dedicated as Curing Stomach Cancer Month. Please see our website's advocacy page for more information about this month and to have this declared in your state. For more information about these and other events, please visit our website and click on Events. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday, 8 a.m. to 5 p.m. Eastern Time. Also on this slide, you'll see important phone numbers and email addresses which you can use to contact our office. We will now begin the presentation made possible in part by our title sponsor, Boston Biomedical. The topic this month is Unraveling Ascites and Peritoneal Disease and Gastric Cancer, a Fluid Problem. Our speaker is Dr. Samuel Klempner of the Angeles Clinic and Research Institute. Dr. Klempner is a clinical and translational researcher with a focus on experimental therapeutics and solid tumors. His research is focused on exploiting tumor genetic features to guide targeted therapies and combination immunotherapies. He's clinically focused on esophagogastric cancers and oncogene-driven tumors. Dr. Klempner completed his residency in internal medicine at Brigham and Women's Hospital at Harvard Medical School, followed by a combined hematology and oncology fellowship at Beth Israel Deaconess Medical Center of the Harvard Medical School. He's presented research at several professional conferences and published in prestigious journals, and we thank him for joining us today. And now, Dr. Klempner, I will turn the webinar over to you.
Thank you, Mary Margaret. Thank you to Debbie's Dream for inviting me and for putting on these educational symposia. I'm going to try to address a topic that I think is understudied in gastric cancer, which is ascites and peritoneal disease. My name is Sam Klempner. I'm a GI oncologist with a focus in gastric cancer. Next. These are my disclosures. I'm born and bred in Boston and a diehard Patriots fan. Next. So my grandfather used to say that you should try to understand the who, what, where, when, why, and how of any problem. And so I'm going to try to give an overview of that with regards to ascites and peritoneal carcinomatosis, starting with what is this problem, who gets this problem, why did they get it, and why is it important? And how do we go about trying to address this problem both now, in the past, and more importantly, in the future? Next. So to understand peritoneal carcinomatosis and ascites, you have to understand the peritoneum. And this is essentially the abdominal cavity space in between the organs. So normally, all of the organs in the abdomen, and here this top picture shows someone cut down the middle, with the liver at the top, the stomach, and then the intestine cut on end as if you were cutting a pipe. And you can see that the blue lining is this smooth silvery lining that covers the organs almost like a lubricating surface. And it covers all of the intra-abdominal organs. And then on the inside of the abdomen itself, there's a lining which is depicted in red on the picture, which is the parietal peritoneum. So there's a parietal and a visceral, and you can think of this as like wrapping saran wrap around all of the organs, which is what I'm depicting in the lower figure. And the space in between those two layers, which are really reflections on each other, is called the peritoneal space. And it's really a theoretic space that's occupied by a small amount of fluid, usually about 50 milliliters, which is primarily used for lubrication so the organs can slide over each other. Next. So to put this, this is what the surgeon can see. If you put a camera inside the abdomen, you can see that normally it looks nice and shiny and clean. And this is the surface of several organs, including a piece of the stomach, some intestine, and the liver. And then in the upper fields, so in B and C, that's the inside of the abdomen. So looking from the inside at the back of the abdominal wall. And again, you can see it's nice and shiny and clean. Next. So ascites is when there's abnormal fluid in this space. So as we said, normally there's about 25 mLs or 50, which is quite a small amount. And that's the top left. On the upper right, you see that the blue is fluid that's not supposed to be there. And that can happen for several reasons. In the green, this is a cross-sectional image of a CT scan of someone with no ascites. And where the arrow originates, there's a very thin line, that's normal fluid. In the red outline figure, that perpendicular line is showing a space that's occupied by a bunch of fluid and pushing the liver more towards the center of the image. That's fluid that's not supposed to be there. So like a lot of plumbing problems, there's two ways to really get there. One, you clog the filter, which is primarily problems with the liver getting backed up or clogged up from cirrhosis. This is not a major problem for patients with gastric cancer. Part B is the main reason for stomach cancer patients getting ascites. So things that aren't supposed to be there that are stimulating extra fluid production. So cancer, infection, pancreatitis when the vessels can get very leaky, and something called nephrotic syndrome where people lose a lot of protein and get leaky. Next. So this is what it looks like. In the top is the same repeat of that picture showing the nice smooth inside of the abdominal wall. And then in the lower figure, you see those little white plaques. That's actually tumor on the inside of the abdominal wall. So it tends to form these very thin plaque-like structures, which are tumor deposits. And this is problematic because it's very difficult to see on CT scan, which we'll discuss. So cancer involving the lining of the peritoneum is the definition of peritoneal carcinomatosis. And this is a common problem for stomach cancer, which I've highlighted, and it's estimated that nearly 50% of people will develop this problem during the course of their disease. Next. So this is sort of a figure. You have to understand how ascites works and how these people get peritoneal disease. And this is a graphic from a nice review actually looking at ovarian cancer, which is a tumor type that has a lot of peritoneal disease. So essentially the tumor cells have to detach from where they started, whether they invaded through the stomach or detached from a lymph node. And in the bottom of this figure, you can see that we know a little bit about some of the changes in the program of the cell that allow them to do this, but this is primarily from ovarian cancer. Next, they have to find their way into the current. Normally, fluid kind of circulates in the abdomen in an organized way to make sure that all the organs are lubricated over each other. And the cells have to be able to survive in that environment, detached from each other. Then they have to find their way onto a part of the abdomen to set up shop. And that involves a communication between the cancer cells, the cells that are normally in the abdomen, the mesothelial lining cells, and the immune system. The peritoneal cavity is an immunoactive area of the body. However, this is generalizations, and we don't understand yet fully why some people develop ascites and others don't. Next. So for the sake of definitions, ascites and peritoneal carcinomatosis, they're highly related to each other in gastric cancer, and it's essentially driven by the presence of cells in the abdominal lining where they're not supposed to be, which drives the production of the excess fluid, which is ascites. They're associated with nonspecific symptoms. Often people don't know that they have fluid in the abdomen until there's already over 1 liter. And this is associated with sort of vague abdominal discomfort, some early satiety, getting full quickly, and sort of generalized fatigue. Unfortunately, this is a common occurrence in gastric cancer and carries a poor prognosis, which we'll discuss. Next. So to sort of get a scope of this problem, because it's a significant problem, we take just a step back and look at the World Health Organization data for gastric cancer in general, which Mary Margaret already touched on briefly. But as many of those listening probably already know, there's wide variations in the incidence, which is the sort of number of cases, with the highest rates being in Central and Southern America as well as Asia. And then the death rates sort of parallel the same patterns. Next. So to put some numbers to that, if you think about the number of deaths from stomach cancer globally in a given year, estimates of about 750,000, which is almost 9% of all cancer deaths. And if you factor in esophageal, which I've highlighted on the lower corner, it almost gets up to 1.2 million, which when you add those two together, it's almost 13% of all cancer deaths. And then almost 1 million new cases of stomach cancer per year. So if you think about 50% of those people getting peritoneal disease, potentially, that's a significant number of cases for which we don't have quite effective therapies. Next. So who gets ascites and peritoneal disease? So we know some risk factors, and again, this is a picture of the stomach, and the red line that I've drawn is that would be the visceral peritoneum, so the peritoneal lining on the outside of the stomach. So obviously people who get ascites are those patients with peritoneal disease, and again, that's between 40 and 50% of all stomach cancer patients. Interestingly, and for reasons we don't understand, it seems that women, much more than men, get peritoneal disease and ascites. Certainly gastric tumors, much more so than gastroesophageal junctional cancers. Patients who have lymph node metastases, so that cancer cells have already figured how to get from the stomach to the lymph node, and now they're making the next step right into the abdomen. And then those patients who have a linitis plastica appearance, which is more commonly associated with diffuse type stomach cancer. Next. So this is a very recent poster from our ASCO conference in June of this year from the excellent group at MD Anderson led by Dr. Ajani, where they looked at patients who were going to surgery, and prior to surgery they had a camera put into the abdomen and washed, and there was no cancer cells in the abdomen at the time before therapy. They went on to get appropriate therapy, and then they went on to have surgery, and they looked at patients who developed peritoneal recurrences to try to figure out what were the risk factors. And as you can see in table 2, women significantly higher percentage than men, deeper invading cancers, signet ring cells, which is a feature commonly associated with diffuse disease, and finally diffuse disease itself if you look at the bottom. And in figure 2, you can see that these patients who develop a peritoneal cancer recurrence, which is the dotted red line, unfortunately have a quite poor prognosis. So again, just highlighting the seriousness of this problem. Next. So unfortunately, although we know about this problem, it's very poorly represented in many of our clinical trials, and unfortunately these patients are not captured very well. So if you look at some of the large phase 3 trials that guide, how we take care of patients with advanced disease, you see that the majority of these large trials, which are considered important studies in the management of gastric cancers, a lot of them either did not report or did not include ascites or peritoneal carcinomatosis. 2 trials which did are worth mentioning, the Rainbow study and Regard trial, which are both studies involving ramucirumab. You can see that the presence of peritoneal metastases was almost half the population. This is sort of reflective of the real world. And peritoneal metastasis in the Regard trial was a slightly lower percentage. And what you see is, these investigators should be commended for including these patients because it's an important population for which we really don't have a lot of clinical trial data. Next. So within those 2 studies, if you look at the people who had peritoneal disease, and specifically ascites is not shown here because it wasn't reported, but in the Rainbow trial, you see that patients who had peritoneal metastasis, yes. You see that this is what's called a forest plot. You see that the line crosses the midline 1, and this is a feature of forest plots where we raises some concern about whether or not that population is truly benefiting from the therapy as much as those who are without, where you see that bar is fully to the left in favor of ramucirumab. Same thing with the Regard study. You see that the presence of peritoneal disease looks to be associated with a less benefit from the addition of ramucirumab versus placebo in this trial. So suggestive, but not proof, because this is a subset analysis, that these patients don't do as well. Next. So there's a lot of interest, and rightfully so, in immunotherapies in gastric cancer. And this was a little bit of a disappointment when this data was presented. This is the phase 3 ONO-12 trial of nivolumab in gastric and esophageal patients who have previously received other therapies for advanced disease. If you look at the breakdown of different patients, although on the whole, if you look at the top left, on the whole, there was a benefit to nivolumab. And certainly this is very, very exciting, and those of us involved in gastric cancer are eager to have access more broadly to these therapies. But if you look at the people who had peritoneal metastases, you see that, again, this bar crosses the 1, suggesting that these people are deriving somewhat less benefit. Next. So why is it so bad? Moving on to the why. 1, of course, this is a definition of advanced disease. Patients who have ascites and peritoneal disease, that is malignant ascites, are by definition stage 4. It is associated with the worst performance status. So people who have ascites, they tend not to be in as good of shape in terms of being able to qualify for clinical studies. And that's because this is a very symptomatic problem to have. It impacts both nutrition, pain, all aspects of people's life. It complicates the ability to receive standard therapies, which is part of the reason these patients are excluded from clinical trials. It's difficult to measure the response because it's hard to put a measurement from a CT scan on disease and say that the tumor has improved or not. The fact that we don't have a lot of data means that there is not a lot of guidance in terms of how this problem should be approached. So if you went to an oncologist in one part of the country and another in another part of the country with a new diagnosis of gastric cancer, largely the therapies would be similar. But if you went with a diagnosis of ascites and peritoneal disease, much more variability, which is just reflective of the fact that we don't have the information we need. And a lot of community spaces may not have access to all of the supportive care that's necessary to care for ascites and peritoneal disease. This may be paracenteses, enteral nutrition, etc. Next. So in summary, the WHO part, this is a significantly understudied problem in gastric cancer where we really don't have the information we need. Unfortunately, this identifies a population of patients who may derive less benefit from our currently available therapies. And people who have later stage disease, meaning node positive or deeper invading, women, and people with perhaps diffuse and signature cell features have a higher risk of developing peritoneal disease. Next. So now we're going to talk about the meat of the lecture, which is the how. How do we deal with this problem? So first, early recognition. And I'm going to highlight what I feel is an important procedure, that's laparoscopic staging. Surgical maneuvers, so is there anything that you can do at the time of surgery when patients don't have metastatic disease to reduce the risk of peritoneal recurrence? And then in patients with advanced disease, which is just the majority, some general approaches, which is you need to have an adequate baseline so you can determine if the patient is benefiting. You need to be willing to frequently reassess and quickly transition between therapies because, unfortunately, response in these patients is important because it's associated generally with improvement in symptoms. Next. So before we talk about laparoscopic staging, I have to walk back a little bit to how we stage stomach cancer in general. So most patients undergo a CT scan to look for distant disease and regional lymph nodes, and this would be chest, abdomen, pelvis generally, often done in conjunction with a PET scan. Upper endoscopy and upper endoscopic ultrasound are standard procedures to look at the depth of invasion, and that is a very common approach. Unfortunately, peritoneal disease is quite difficult to appreciate on CT for those exact features of those small plaques. In fact, PET CTs, which are considered, some of our better imaging modalities, only have a sensitivity of 50% for detecting peritoneal disease. Number 3 is really an important point on this slide, and so I'll spend a second talking about it. Patients who have deeper invading disease on ultrasound, so T3 or T4, you can see this is tumor that has invaded basically through the layers of the stomach into the tissue next to the stomach or directly into adjacent organs. And even though in those patients you may know that they have a tumor on the CT scan, if you may not see, and in those patients who have a negative CT for peritoneal disease, up to 20 to 25, so 1 in 4 patients may have disease that's visible when a surgeon puts a camera into the abdomen during a laparoscopy, or even if they don't see anything, if they wash out the abdomen, there's nearly a 20% chance that that patient may have positive cytology, meaning cells in the fluid that are not appreciated in other ways. Next. Again, so this is the difference. So you see these small Those small plaques are quite difficult to see on a CT scan, in fact, often impossible. So laparoscopic staging, putting a camera inside the abdomen, allows the surgeon to get a preview of what is in there and diagnose stage 4 disease if that's present. Next. And I'm just highlighting this, which is the NCCN guidelines, one of our large cancer guidelines, showing that diagnostic laparoscopy with cytology is considered, should be considered as part of the workup for gastric cancer. The reasons being, if it's present, it's diagnostic of stage 4 disease. So these patients with stage 4 disease have a different prognosis than those with non-metastatic disease. So this is a quite important distinction. And if you know this at the time of your workup, it would change your treatment approach and goals. Also, when patients go back to look and undergo surgery, it may be saving them from an unnecessary surgery, although this is an open question, which we hope to have more data to guide. Equally important, diagnostic laparoscopy also has the capability of identifying these patients. That is the exact population we need to study. You know, how do we find these patients if the imaging doesn't work? Unfortunately, diagnostic laparoscopy is probably the best way. And then we can actually study some of these questions. Washing in the abdomen can identify peritoneal cells, which is a poor prognostic factor. And again, this is endorsed by the guidelines. Next. So we're going to talk a little bit about things that you can do at the time of surgery, or research questions about what can be done at the time of surgery. But before doing that, you need to understand slight differences in definitions. So HIPEC and intraperitoneal therapy are actually quite different. HIPEC, which is essentially heated intraperitoneal chemotherapy, this is generally done when patients are anesthetized for surgery and the surgery has been nearly completed, and the surgeon and the team essentially connect the patient to a machine via some drains. And the machine pumps in this place via an inflow catheter number 4 in the figure that puts heated intraperitoneal chemotherapy in, and then there's an outflow catheter number 5. And so this is a one-time event that usually happens at the time of surgery, as opposed to intraperitoneal chemotherapy, which is more like traditional chemotherapy, except the drugs are going into the abdomen instead of into the port. So many patients have a portacath on their chest. Chemotherapy goes into a central vein, and this is repeated at regular intervals, every 2 weeks, every week, depending on the combination. Same principle for intraperitoneal therapy. These is where you have a port put into the abdomen, a surgical procedure, and patients and nurses access the port, and chemotherapy is put directly into the abdomen in a much smaller volume. It makes its way around in the abdominal cavity, and then this can be repeated. Next. So this is an older trial, in fact, from the early 90s, looking at this idea. Logically, you would think that if there's something you can put in the abdomen to reduce the risk of peritoneal carcinomatosis as a recurrence, then these patients would do better. And so this was an early trial looking at that question. So these are patients who had negative staging laparoscopy, so they had the full workup to determine that they were non-metastatic. And then they were split between 2 groups. One group got a variation of HIPEC, and the other group got none. And what these 2 figures are showing is that although this was not a statistically significant improvement, there was a trend towards improved survival and decreased mortality rate from peritoneal recurrence. So this was sort of hypothesis generating data, older techniques, higher mortality from surgery at that time. Next. So there's been a lot of literature, and I don't have time to do it all justice from the surgical world, but this is a more recent meta-analysis looking at multiple trials trying to investigate adding something at the time of surgery, in this case HIPEC, on 5-year overall survival. And what you can see here is that at 5 years, based on these generally older studies, we haven't yet proven that adding something into the abdomen at the time of surgery clearly improves survival at 5 years. I will note this with the caveat that these are generally older studies. Surgical techniques have improved. perhaps biologic understanding has improved, and there are multiple trials which suggest that there may be an improvement at earlier time points, such as 1 and 3 year recurrence patterns. Next. So all of that data is very encouraging, in my opinion, and I did a quick search before this lecture just last week looking at the clintrials.gov, which is a government-run website I would encourage gastric cancer patients to explore. This is all of the larger trials looking at refining that, trying to find those people who have non-metastatic disease and are going to go to surgery. They get the normal surgery that they would normally be having, and then adding something in at the time of surgery to reduce the chance of peritoneal disease. So there is a lot of excitement about this field, myself included. Next. So the role of surgery in stage 4 disease is worth a mention, even though it's not the main topic, because there was a relatively recent publication sort of investigating this question. This is a trial of untreated patients with advanced disease primarily. You see that arm A, which is the top, are people with non-metastatic. Arm B is people with limited metastatic disease. And this included some people with P1 or P2, which is limited peritoneal carcinomatosis. And then arm C is advanced patients not meeting arm B. So these patients got a chemotherapy regimen called FLOT, which is an interesting regimen. Next. So if you focus on the group arm B, these are the patients who had, some of whom had limited peritoneal disease. You see that after 4 cycles of FLOT, these patients, those who went to surgery, seem to have a significantly improved outcomes, in this case 26.7-month progression-free survival versus an 8.4-month progression-free survival from this phase 2 trial, suggesting that patients who have a limited burden of disease and have some response or control on chemotherapy may benefit from surgery. Next. So unfortunately, that's the minority of patients, and most patients we interact with have advanced disease with peritoneal carcinomatosis and ascites that would not generally be candidates for surgical procedures, as we saw with the prior trial. So then you have to think, what are the goals of therapy? Of course, prolong survival, and do so with palliation of symptoms and a good quality of life. We think about what tools we have, so symptom-directed therapies, such as paracentesis, which is draining the fluid directly from the abdomen, nutritional support to try to minimize the losses, and then our systemic therapies and potentially therapies into the abdomen. And then most exciting is what is the future. Next. So this is a study that's somewhat older now, from 2000, called the EvoCape-1 trial, and this was basically looking at what is the natural history, what happens to these patients essentially untreated. And so please understand that this is from a period in 2000 when many of the gastric cancer therapies we currently use were not yet in existence. So these outcomes have to be re-examined and should be taken with a grain of salt. But certainly the median survival for people with peritoneal disease, there you see ranging in the 2 to 3 months, and people who have ascites in addition, even worse outcomes. So this is obviously a group of patients who need improvements in therapies and have a poor prognosis. Other cofactors such as lower extremity edema, like swelling in the feet, low protein in the blood, low albumin, and the presence of liver mets may identify people who do even worse. So just highlighting the severity and the unfortunately poor prognosis and outcomes generally associated with ascites and peritoneal disease. Next. So unfortunately, this has been biologically, this is a rich place to obtain samples for study, but it hasn't been. So we're just starting now, and I would argue that even now we still don't know what is the makeup of ascites and peritoneal carcinomatosis cells, and how are they different than the gastric cancer that's in the stomach. So this is a cartoon on the left showing the normal cells that are in the peritoneum in peritoneal carcinomatosis. So you have a tumor cell, you have a T cell, part of the immune system, and then you have macrophages that are also part of the immune system. And there's some complex interactions, and This is a theoretical slide in which cancer cells have multiple ways of avoiding the immune system, and these are some of the ways that may exist in the peritoneum to do that. So we know there's immune cells, we know there's tumor cells, we know there's other stuff, but we really haven't characterized it very much. Next. So I'm going to go over the limited data that is out there to look at the differences between peritoneal carcinomatosis cells and primary gastric cancers. This is from a scientific report article in 2015. It's actually a single patient where they looked at an area of gastritis, which is a non-malignant inflammation in the stomach. They looked at the patient's primary stomach tumor, and they looked at the peritoneal tumor, and they did gene sequencing and RNA sequencing. And so this is the RNA sequencing data showing that genes that are going on to be made into proteins. And you can see that there's significant differences in the program, like the genetic program, about what the tumor is doing between the primary tumor and the peritoneal tumor. And so you would wonder if these are part of the reason that, you know, the primary tumor may respond, but the peritoneal tumor may not, or explain why peritoneal carcinomatosis and malignant ascites tends not to respond as well. So why don't we know more is a very fair question. Again, this is a single patient. It's hard to get these paired samples, so most patients have a biopsy of their stomach to make the diagnosis, but oftentimes the samples of the ascites fluid or peritoneal are not reanalyzed with the same rigor, or may even be discarded in some cases, and they may offer some potential information. Also, our large series looking at the DNA sequencing has not included these patients. Next. This is another series looking at 8 patients, looking at the spectrum of mutations. So these are the types of mutations that are happening in the patient's tumor. And you see that P1 through 8 at the bottom of the figure are the individual patients, and PT is the primary tumor, and A is the ascites tumor cells. And you can see that for the most part, there's pretty significant differences in the breakdown of types of mutations between the primary and the ascites tumor cells. And you knew that there had to be some differences because these tumor cells exist in different environments, so they have to make some adaptations. But equally interesting is that if you look at patients 5 or 2 or 3, you see that there's actually a lot of overlap. Some patients are very similar and some patients have significant differences in the spectrum of mutations. Next. So again, this is from the same paper, and up on the right, what I'm showing you is that the pathways that these genes are involved in are some of the ones you might predict. So cells need to be able to break free, so cell adhesion pathways are dysregulated in the ascites. T-cell receptor signaling is upregulated in the ascites fluid. So this is some early data basically proving that there is differences between the primary and the ascites, and that's something that we should think about when we're trying to develop individualized therapies. Next. So this is what little we do know about trying to manipulate the immune environment and the makeup of ascites. So this was an antibody called catumaxomab, which was developed for patients with malignant ascites, so cancer-associated ascites. And essentially what this antibody did is it tried to bring tumor cells in the upper left of the left figure, immune cells, and then other cells which express Fc gamma receptors into close proximity. Because if you just bring these cells together, that's enough for sometimes them to recognize each other and for the immune cell to kill the tumor cell. And so what they showed in this small trial is that patients who were given this antibody directly into the abdomen, one, they had a decrease in the need for ascites drainage, and two, they had manipulation in a favorable way of the environment within the abdomen. So there was more activated T cells, and there was a reduction in some cancer stem cell-like cells in the abdomen. Next. And so this was a great effort, unfortunately, that was cut short by the group from Gustave Roussy, looking at if that works in advanced patients, what if patients at the time of surgery, we give them an intraperitoneal injection of this antibody to try to reduce the chance of peritoneal recurrence. So essentially what they're saying is that some of these patients we know probably have 1 or 2 cells hiding out that we can't see, and that's why they come back in the abdomen. So if you could inject something at the time of surgery directly into the abdomen, this is like intraperitoneal immunotherapy, then you may be able to create an environment that's hostile to those cells and prevent the recurrence. Unfortunately, this trial was stopped early due to the stopping of manufacturing of the drug. Next. So again, we talked that there's immune cells and tumor cells inside the ascites and the abdomen, but there's also some signaling molecules, which is how cells, part of the way that they talk to each other. And some of them have, they can drive inflammation, they can suppress inflammation, they can drive leakiness. So VEGF is a growth factor for blood vessels, and high levels of this are known to be associated with leakier vessels and ascites and actually worse prognosis. So what this figure is showing, that patients who receive this antibody into the abdomen, intraperitoneal immunotherapy, had a reduction in the level of VEGF as opposed to those who did not get the injection, which is on the right side. So although this was an overall trial which did not clearly show a survival improvement, it was proof of principle suggesting that by putting therapies into the abdomen, you can manipulate what's going on in there. Next. So again, one of the things we think about when we think about the peritoneum is that this is an immunosuppressive environment, and cancer stem cells may be some of the cells that are surviving in the abdomen and driving the immunosuppressive environment, and they may require slightly different ways to target them. And so again, this is showing that CD133 positive tumor cells were reduced by adding intraperitoneal immunotherapy compared to those patients who did not get this group. I did not get the therapy. Next. So this is a little bit of our own work looking at just 6 stomach cancer patients who had peritoneal carcinomatosis and malignant ascites, just to try to say the question, what is the breakdown of the immune cells inside the abdomen in these patients? And what we found is, this is very preliminary and only 6 samples, but you can see that there's a lot of variability. So this begs the question of, should patient number 3, who has a lot of macrophage cells in the abdomen, be treated the same as patient number 4, who has a much higher proportion of CD8 positive T cells? We have differing therapies that can activate CD8 versus macrophage populations. And this is a question that other people are working on as well, and I think holds a lot of promise. Simply understanding what's actually in there and what we can manipulate to try to exploit potential weaknesses for therapies. So ideally individualizing therapy for ascites and peritoneal disease. Next. So this is just a hypothetical picture of showing what I envision and what others have sort of proposed could look like. So this is a potential patient who has peritoneal carcinomatosis and malignant ascites. The red line is essentially the number of tumor cells in the fluid, and the other lines are basically immune-relevant substances and populations of T cells. And so a patient gets intraperitoneal therapy or systemic therapy. You know that it's working by a decrease in the number of cells and a decrease in the level of certain cytokines. And then those continue to stay low. And in theory, you would be able to identify when your therapy was not working early on by changes in these levels through sampling of the abdominal ascites. So this is hypothetical. This is not what we're doing in practice yet, but in theory, this is doable. And we hope to have information where someday we could be following patterns similar to this. Next. So I know I don't want to run overtime, but what about just giving chemo into the abdomen, getting the tumor cells directly in proximity with chemotherapy? So this has been investigated in stomach cancer on several trials and other tumors as well. So this is the phase 3 Phoenix gastric cancer trial. And one thing you note is that frequent ascites was excluded, so no one with frequent ascites was allowed into the trial. And essentially what they did was ask does the addition of giving chemo into the abdomen improve survival? So all patients got standard chemo regimens. This is primarily a Japanese study, so S1 and cisplatin, or S1 and paclitaxel. This is the standard chemotherapy. Experimental group got chemo into the abdomen. Next. And unfortunately, if you lumped everyone together, there was not an improvement in overall survival by adding in chemo directly into the abdomen. So this was a little bit of a blow to the idea of just putting chemo right into the abdomen, the same chemo for everybody. However, next. These investigators did a sensitivity analysis to look at certain groups of patients that were imbalanced a little bit in their population. And what emerged from this, which is a subset analysis, is essentially people who had a larger amount of ascites when they started on the trial, so top right of this figure. Those people did have a survival improvement with the addition of intraperitoneal chemo. So this is interesting. It suggests that if we get better about identifying these people, we may be able to individualize this a little bit and identify groups of patients who may benefit from intraperitoneal therapies, and there's a lot of ongoing work here. Next. So in summary, this is a complex interaction in the abdomen of the tumor talking to the immune system and using signaling molecules for all these cells to talk to each other. Unfortunately, we don't have standardized therapies for ascites and peritoneal carcinomatosis. Although encouraging data for some intraperitoneal therapies, this is still considered investigational. It's somewhat embarrassing as a gastric cancer research community that we know quite little about peritoneal carcinomatosis and ascites in terms of the breakdown of immune cells and tumor cells and how they differ from the primary. But as a collaborative effort, characterizing this, I think, offers a lot of new strategies towards targeting this understudied population. Next. Here are my overall conclusions. Essentially, this is a major problem associated with a poor prognosis and no standard therapy. These cells are different. There's differences in the peritoneal cells and the immune makeup between that and the primary tumor. And there is a lot of opportunity here and interest internationally to study these questions. Next. So this is an important area, as are many other areas of stomach cancer, and I would encourage caregivers and patients to keep asking questions of their treatment team, ask about opportunities for research, share your stories with others, something that worked for you. Maybe you'll find something that will help us improve outcomes for gastric cancer in general. And I will turn it back over to Debbie Stream and Mary Margaret.
Thank you so much, Sam. What we'll do now is go ahead and take a look at the questions that we've received during the presentation that you gave. We really do appreciate your comprehensive overview of the treatment. So the first question, there's a couple of questions here that are kind of background regarding ascites and what they mean for the overall prognosis. The first is being that, does the occurrence of ascites indicate advanced disease, i.e., like, for example, that is a metastasis, or does it only occur in stage 4 where other metastatic disease is already taking place?
It's very rare for ascites to occur in gastric cancer without stage 4, so it can either be the symptom and the way that we figure out patients have stage 4 disease, so someone who had stage 2 tumor and then a year later developed fluid in the abdomen. If there's tumor cells in that fluid, then that proves that they have stage 4 disease and recurrent cancer. It's very rare for gastric cancer patients to have ascites or fluid in the abdomen that's not related to the tumor. Of course, it is possible that that patient may develop, cirrhosis from alcohol and then get ascites and has nothing to do with the cancer, but unfortunately, that's the vast minority. So it's either the presenting symptom of stage 4 disease or something that when it happens, it is diagnostic of stage 4 disease. Okay,
great. Thank you. Now, is the way that you're talking about stage 4 and ascites presence, is that the same thing as malignant ascites, or is there a differentiation with the use of malignant in the term?
Yeah, so for the purpose of my talk, when I mentioned ascites, I was referring to malignant ascites. By definition, if there's tumor cells floating around in the fluid that you sample, then that is the definition of malignant ascites. As I said, with alcoholic cirrhosis, there can be ascites in which there's no tumor cells, and that's referred to as just ascites. So I apologize if that wasn't clear.
No, I appreciate giving that background. So how common, in your discussion regarding staging with laparoscopy, how common is laparoscopy during staging? Is it considered a standard?
So it is a category 2B on the NCCN guidelines, which means that there is not randomized phase 3 data to say that staging with laparoscopy clearly improves overall survival. However, there is enough evidence to suggest that it's an important component, and in my opinion, it is underutilized. So across the U.S., laparoscopic staging is not as common as part of the staging, but at centers where they see a lot of stomach cancer, I would say that the majority of them, our center included, for patients who have endoscopic evidence of a tumor that's invading beyond T1, we are recommending laparoscopic staging as a consideration to identify this peritoneal disease that's not seen on CT in about 20% of people. So it's not as common as you would think, and that, in my mind, that's a problem.
Okay. Thank you for that. Just as a follow-up, my own question to that, do you find that there's any difficulty in having that additional staging through laparoscopy through, third-party issues or getting approval?
I think
do you think that's part of the consideration?
I think it's, I don't know the exact answer as to why it's not incorporated into the workup of more patients, but some of it has to do with the presence or absence of multidisciplinary review boards, so tumor boards and multidisciplinary teams that have familiarity with doing this, as well as just penetration of knowledge of what can be said and what questions can be answered with laparoscopic staging. So the fear is always, and this is a scenario that probably many people have heard, is that a patient was under the impression that they had, stage 3 gastric cancer, they got chemotherapy, and then when they went to surgery, the surgeon opened them up only to find that there was some peritoneal disease inside the abdomen. And so without laparoscopic staging at the beginning, you don't know if that patient developed that during the treatment because the treatment wasn't effective, or if it was there in the beginning and perhaps it's even better now, but without a baseline at the beginning, you don't have anything to compare to. So that's always been one of the arguments for laparoscopic staging, because if you know ahead of time, perhaps you would change the therapy, perhaps the patient would be able to participate in some research on a therapy that may be more targeted towards the peritoneum. I hope that helps to answer the question.
Absolutely. No, thank you. Thank you for that. The next question that came in is that there is a perception of ascites as being an end-stage issue, and I think that really speaks to the prognostic information that you were sharing with us. Can you address that as it being an end-stage issue?
So unfortunately, the data does suggest that the presence of ascites is a marker of people that have a poor prognosis. And so considering it an end-stage issue is probably a view that's shared by many. That is true, and the data is the data, so we have to have important discussions with patients when we identify malignant ascites. But at the same time, it's a opportunity to investigate why this happened, perhaps understand a little bit about that own individual's ascites and use that information to guide therapies, just like we use HER2 testing and microsatellite instability testing in stomach cancer to guide therapies. Ultimately understanding the ascites, we may have some similar biomarkers to guide our ascites, but What is true is that the presence of ascites is associated with a poor prognosis, and having a discussion of the goals and expectations when that is identified, I think, is important for having realistic understanding with all patients who this is identified.
Thank you. And for the sake of time, we have time for one more question. I'm actually going to combine a couple because they seem pretty similar. So are there any successes in other cancer types, and possibly diffuse cancer types such as lobular breast cancer, that could be translated for GI and gastric therapies?
So that was I'm not an ovarian cancer doctor, but there is phase 3 trial data suggesting that in certain ovarian cancer populations, giving chemotherapy directly into the abdomen actually significantly improves the overall survival. And so that was the sort of the foundation that has driven a lot of the gastric cancer interest in copying the same strategy. Unfortunately, as the Phoenix gastric cancer trial suggests, it may be biological differences which we don't understand, but the exact same sort of theoretical approach doesn't have the same success in stomach cancer. So we have yet to sort of find something that we can take from another tumor type that may have some success in peritoneal disease and translate that to gastric cancer. Unfortunately, peritoneal carcinomatosis from other tumor types, colon cancer being probably the next most common and relevant, is also associated with a poor prognosis in that disease. So they don't have good therapies for those patients, and we unfortunately don't yet have good therapies for our own patients. But I think fundamentally understanding what's actually in there and the makeup will help us sort of identify the best strategies.
Thank you so much. And Dr. Klempner, I want to thank you for taking the time to go through those questions with us, as well as for your presentation and your time today.
Yeah, thank you. Anytime.
And for everyone listening, as you know, this webinar was brought to you by Debbie Stream Foundation Curing Stomach Cancer. Thank you again to Dr. Klempner for joining us and providing us with this vital and important information. The recorded version of this webinar and all of our past webinars can be found on the lecture library of our website. We'd like to thank our sponsors who helped make this webinar possible, our title sponsor, Boston Biomedical, and our platinum sponsor, Lilly Oncology. As a reminder, please check our website and your calendars to join us for an event near you. And thank you to all of our listeners today. This concludes our 6th in a series of 12 webinars. Our next webinar will be on August 25th at noon regarding financial issues and costs of care. To view our recorded webinars, again, please visit our lecture library. We would love to hear your feedback, questions, and thoughts before that time of our next webinar. Please send your comments to patient.resource@debbiestream.org. Thank you for joining us today.